Welcome everyone to today's Mind Opener event. My name is Bridget Callahan and I'm the Public Affairs and Civic Engagement Specialist at Blue Cross and Blue Shield of Minnesota. Blue Cross has been partnering with Citizens League for nearly 30 years and we are thrilled to be sponsoring the 2020 Mind Opener series. The Mind Opener theme this year is on the social determinants of health. And each of the 6 events in this series is dedicated to talking about a different social or economic condition that affects health. These social determinants are the underlying contributing factors of health inequities that unfortunately exist throughout our society and particularly here in Minnesota. So far in the series, we've discussed how issues such as housing, education, and food justice affect one's health. And today we're here to discuss structural racism in healthcare, and in particular, the mental and physical health impacts that racism has on Black mothers. At Blue Cross, we believe that structural racism, which permeates through all of the social determinants of health, is a public health crisis. Today's discussion is directly related to our business, and I'm excited to welcome some of my colleagues to today's event as well, as we continue the critical work of embedding racial and health equity into the way that we do business. We're fortunate to have this opportunity to learn from our incredible panelists that we'll be hearing from shortly. With that, it's my pleasure to introduce Amanda Kunj-Bahari, Director of Public Policy at the Citizens League, who will tee us up and introduce our speakers. Thank you.
Hi, everyone. Happy Friday. Thank you all so much for joining us, and thank you, Bridget, for that introduction and for the long-standing partnership that Citizens League has had with Blue Cross and Blue Shield of Minnesota. For those who are on today's webinar who are not familiar with the Citizens League, we are a nonprofit, nonpartisan organization that's member-based, and we've been around for over 60 years here in Minnesota, promoting civic engagement and democracy. So thank you again for joining us. I have the esteemed pleasure of being able to introduce our presenter and moderator today, who will then introduce our panelists for the conversation. It is my esteemed pleasure to welcome Asha Hassan. And a little bit about Asha. Asha is a health services researcher and epidemiologist focused on studying how racism impacts reproductive health throughout the life's course. She is currently working towards her PhD in health services research at the University of Minnesota, while also serving as the Associate Research Manager at Planned Parenthood North Central States. Asha is the primary investigator of a national study to assess relationships between tear gas exposure utilized by law enforcement and the negative reproductive health outcomes. Asha, it is my pleasure to welcome you. Thank you so much for being here.
Hi, and thank you, Amanda, for that introduction. And thank you, the Citizens League and Blue Cross Blue Shield, for this opportunity. Just give me one moment to get my PowerPoint up and running. Okay, folks, today I will be giving a quick primer on structural racism and maternal health and how those two things intersect. My name is Asha Hassan. You can feel free to email me if you have any follow-up questions. My email is at the bottom of this slide. Structural racism thrives in the American healthcare system. There's a really great shot right here to the right of our wonderful healthcare workers who have been bringing this to attention in recent months. What we have is several different types of racial inequities that persist in our society, and some of those are health inequities. For an example, health insurance coverage. And sorry, I'm realizing that my PowerPoint is not sharing correctly. Let me just fix that. Okay, so we have several different types of racial inequities that persist in our society, from health insurance coverage to life expectancy, and more recently what we're seeing is COVID mortality and infection rates. And for a long time, we have known these things. We've known that based off of what your race is, you have the chances of having a different experience with your health. What we also know is that researchers and policymakers have been reluctant to investigate the idea that racism may be a piece of this. We have gone through phases of dialogue of whether this is a biological issue. Maybe some people are more likely to die from diabetes or from breast cancer. And what we have learned through science is that there's no genetic marker of race. There's no way for that to be something that makes sense when race is a social construct. Another thing that people talk about is socioeconomic status. So maybe this has to do with poverty, and maybe it's not a race issue. And that doesn't necessarily help us explain certain statistics, like how somebody with a Black woman with a professional degree, a doctorate degree, a master's degree, such as myself, is more likely to die in childbirth than a white woman with an 8th grade education. So I think we need to start investigating racism as a cause for some of these health inequities. And luckily, we have a growing body of research explaining this. So I just want to quickly give some definitions. I know this has been a topic that people have been talking about for a while, but for those who are new to the conversation of different forms of racism, what we're talking about is forms of racism that are below the waterline. So there's the obvious ones that are above the waterline: hate crimes, microaggressions, everyday slights. And then there's the things that are a little bit harder to read. And institutional racism and structural racism are examples of that. Institutional racism is when a specific system or an entity that has power has policies, whether knowingly or unknowingly, that is discriminatory to certain groups, specifically to specific racialized groups. And structural racism is when you combine all of those institutional pieces together and have that compounding effect. So when you think about the housing system and the criminal justice system and the health system, and how all of those pieces might have specific pieces of their policy that may be institutionalized racism, and how those combine to negatively harm specific communities. So I wanted to give a quick example of some institutional racism in healthcare. One example is how research has shown us over the course of the past few decades that 50% of Black people in the United States use about 10% of the hospitals in the country, or have access to only about 10% of the hospitals in the country. These are oftenly termed minority serving institutions, and they tend to be of lower quality. And I think we need to investigate what that says if half of the population of one race in a country only has access to low quality care. Another example is treatment algorithms that are still used in clinical institutions that have race as a factor in what forms of treatment someone gets. I have a quick video explaining that.
In 1988, the Joint National Commission, that's the leading U.S. authority on management for high blood pressure, changes their recommendations for how doctors should treat people with hypertension. They single out Black patients, carving out a new pathway different from the standard non-Black group. The upside-down Y of the recommendation flowchart split its legs to actually end at 2 different medication recommendations. And what this means is that American physicians are asked to consult their eyes and judge the race of the person sitting on the exam room table. Only then can they referee the fitting pharmaceutical.
Okay. So let's dig a little bit deeper and get into the specific topic of structural racism in maternal health. If you look at the diagram to the right, this is a beautifully illustrated chart from Mother Jones, sourced from the CDC, showing maternal death rate over the past few decades. And what it shows you is that the United States has had a steady incline of this across the board, while the rest of the world has had the opposite. Maternal mortality is decreasing around the world and increasing in the United States. But you can also see this kind of alligator mouth. And what you're seeing is this is happening at an increased rate for Black mothers. To kind of put this into words, I was born in 1994. My mother, giving birth in 1994, had a better chance of surviving birth than I would at 26 years old today. I created this diagram to help allow us to conceptualize structural racism in maternal health and think about some of these intersecting pieces. Remember how we're talking about institutional racism as being one specific institution, but how those can combine with other institutions to create a structure of racism. And this is something that's really quite evident when we look at intersecting identities and intersecting forms of discrimination that Black mothers specifically face, whether that is from gender inequity to anti-Black racism or the trials of capitalism. And these can lead to chronic racial stress. These can lead to living in environments where you don't have access to healthy food and beverage. And that in and of itself can lead to chronic racial stress. So this is part of why we are having an issue with the increased maternal morbidity and mortality among Black mothers in the United States. So I want to give a quick example of some of the things that we know work to alleviate these concerns. One of the things that I like to talk about is reframing the goal. I remember when I first saw these images several years ago that I was just blown away by them, is thinking about moving from thinking about equality to equity, giving everybody the same thing to giving everybody what they need. So giving somebody who is in a wheelchair a ramp so that they can look over the fence, and someone who's a little bit shorter, a child, 2 blocks so that they can see over the fence. The example on the right with folks who have bicycles that are designed for their ability and size. I'm asking us to dig a little bit deeper than that. We should be moving towards justice and liberation. We should be questioning the structures that are in place that obfuscate our ability to have success and to have health. So we should be questioning why the fence is there in the first place. We should be questioning why the tree isn't straight and why we can't move the tree in order to make it more accessible for all people. Another thing that we really need to focus on is building trust and respect between healthcare institutions and Black patients. I took a little excerpt from one of the findings of a research article. If a patient perceives that their doctor knows them as a person, they're more likely to have better adherence and health outcomes. And what we know in the United States is that there's a very long history of mistrust between healthcare institutions and providers and Black patients, and that's for good reason. We have things from the very beginning of gynecology, the father of gynecology experimenting on Black women without anesthesia. We have the Tuskegee study in the 20th century of not giving proper care to Black men infected with syphilis. We have the Mississippi appendectomies of the 20th century where Black women would go to the hospital thinking that they had their appendix removed when it was actually their uterus, and systematic sterilization, which we have seen recent reports of in ICE detention facilities. Another thing we really need to think about is diversity in the healthcare workforce. We need to think more boldly about how to diversify the healthcare workforce. From a recent study, including a local researcher and Professor Rachel Hardiman is one of the authors, they found that if the race of the mother and the race of the physician matched, that there was a better chance of an infant surviving. And we can go into why that might be the case, and I think that's going to be a large body of work in the future. But we know what the solution to that is, a very obvious solution, and that's to give Black mothers the opportunity to have providers who look like them and have shared experiences like them. Right now, we have a very bottom-heavy diversity in the healthcare workforce, where medical assistants and LPNs are overwhelmingly people of color. And when you go up the ladder to clinicians, there's less and less options if somebody does want a racially concordant provider. And I want to talk about demedicalizing birth. By that, I don't mean that we shouldn't have people giving birth in hospitals and having access to all of the medical innovation that we have these days. But I do want to point out that sometimes the solutions aren't always through the traditional medicalized system that we know. One thing that we've learned in recent years from another researcher who is local, Katie Cosmanel, is that preterm birth and cesarean rates decrease when a mother has a doula supporting her, a birth attendant, someone who is there to focus on their care. And you can see a picture down below of a woman giving birth at Roots Birth Center in North Minneapolis, a place that has really centered their model on this sort of one-on-one personalized care. So some takeaways I just want to throw at you guys, some things to sit with perhaps. When you're talking about structural racism, are you using racial inequities as a euphemism? We should really investigate when we're using racial inequities and stopping the conversation there. We should really think about what is causing that. And if it is structural racism, identifying that. And that could be in healthcare, that could be in other parts of our economy or in our lives. Another thing I want you to think about is, are we affirming reproductive justice in our approach to solving structural racism? So reproductive justice is the right to have bodily autonomy. So being able to make the choices that you want to make about your body, as well as the right to have a child or not to have a child, as well as to have a child, if you do choose to have a child, to have them grow up in a place and in an environment that is safe. If you don't focus on all three of those things, are we really helping alleviate some of the stress that we saw in the previous slides that are contributing to the stress that Black mothers experience? Probably not. So I would really recommend taking that sort of approach. And that's it for that section. I want to move on to a panel discussion with Monica and Shalon. Hi.
Hello.
Hi.
Okay, just give me 1 second, guys. Okay, so can you start off by telling us a little bit about yourselves and what got you interested in maternal health and well-being? We can start with you, Shalon.
Yeah, sure. So my name is Shalon Wilson. Pronouns are she, her, hers. I'm a mother of 2 little girls, 3- and 4-year-old Zohar and Miriam. And my mothering journey began, I would actually say, at my first pregnancy, which did not result in a live birth, but ended in an ectopic pregnancy in which one of my tubes ruptured. And so that is really the start of that experience. And it was really that experience that I think set a precedent on what my expectations were for the Western medicine and healthcare, and as far as treating mothers, and especially Black mothers. And I think it goes back even before that. I really was interested in this work because at 10 years old, I got to see the birth of my nephew, and I was so intrigued by it, which many people found strange. But there was something odd that was happening with my sister when she received an epidural, and my nephew wouldn't come out, and I remember just her saying things like she couldn't push and all that. And so it actually inspired me to want to become an OBGYN, because it just felt wrong. I didn't actually understand what was wrong, but it felt wrong. And so that is actually what I wanted to be for a long period of time. And had several experiences viewing and supporting births, even in college. And so somehow today, though, I am at Nexus Community Partners as the Human Resources and Organizational Culture Manager. And even today, I'm still finding those connections to what I do now, how they're related to mothers, especially Black mothers' ability to thrive and have healthy pregnancies and healthy lives after their pregnancies, and healthy children. So I'll talk a little bit more about that as we get into the panel.
Awesome. Well, my name is Monica Jones, and I grew up as a military brat, and I came to Minnesota when I was in 8th grade. So I had a really unique experience coming to Minnesota. I was in a predominantly white high school, really kind of struggled with really kind of my identity, just being a teenager in general, but then also, you know, as a Black woman as well. But one of the things that really kind of stuck out to me going to that high school was I was able to do an independent study on being a nurse midwife, which I know, Shalom, you kind of wanted to be into that field as well. And I also did too. And so I got exposed to learning about the different options of birth, like water births and going to a birth center and having a home birth. And so I was very intrigued. And so when I went to college, I thought that's what I was going to do. However, I realized how much chemistry and math and science was involved. And I was like, oh, no, never mind. I'll just get a business and marketing degree. So I got that. I met my husband, and we decided when we got married that we wanted to have a baby right away. We were very intentional about our family planning. And so that conversation again kind of came up on, you know, how were we going to deliver our baby? Were we going to do the hospital experience, or were we going to go to a birthing center? And, you know, I tried to do the hospital experience for my first prenatal visit, and I instantly realized that it just wasn't going to be a good fit for me. It was very cold and sterile, and it just didn't feel like, God, this is supposed to be like the most important time in my life, a very joyful experience. And yet I still feel like I'm just going to get a normal, like, physical or checkup or something. So we ended up going to a birth center, which was an amazing experience, very beautiful, very empowering, and was everything that I wanted and more. And so when we got pregnant with our second, we decided to do another birth center as well. That experience was a little bit different than my first one, and I can touch on that a little bit later in the panel. Yeah, so that's kind of how my experience with birth went. But as far as me getting into this work, one of the things that kind of kept coming up for me as far as kind of just understanding about birth centers and pregnancy and different things like that was the lack of representation. I read all the blogs and watched all of the videos and got all the books on what to expect in this new you know, time in my life, but I didn't see a lot of people that looked like me. And I also didn't hear a lot of stories that were going to actually resonate with my motherhood journey. And so just this year, I actually decided to create a platform and a space where that representation can be there. Started Melanated Mamas, which is an online digital space for BIPOC moms. And it's really a space to amplify the joy and the love that we have in our motherhood experiences, especially when it comes to pregnancy. And I can talk about that a little bit later as well. Oh, and then, sorry, I didn't even say my kid's name. I have a 7-year-old who is 7, and I have a 4-year-old who is Audrey.
Thank you both. I think it's both touched on this next question a little bit, but if you can dig a little bit deeper and give us some more information about the challenges and the barriers that you experienced in the healthcare systems as you embarked on your motherhood journey.
Yeah. So I think largely the challenges and barriers that I had along my journey were mainly about not having a choice or say in my care, and then the quality of care that I received. So I mentioned my mothering journey really started with my first pregnancy that ended in an ectopic pregnancy. And I remember like one of the things that felt apparent to me afterwards is that it really didn't have to end that way for me. And I believe that because I remember I was in like intense pain, and I went into the ER, and they actually sent me home. And even though I was bleeding, and they just said, "Oh, it's a miscarriage," and it was weird to me because I don't ever really remember hearing about that sort of pain. I knew I was very, very early in pregnancy, so it didn't really make sense to me that there would be so much pain. They sent me home, and then I called again, and they were like, "Oh, you should try to get an appointment with an urgent care physician." And so all of this while come to find out I'm in like dire need of surgery at this point. And so I went to see, urgent care, and urgent care was like, "Yeah, you should go back to the ER," and all these things, and it ended up being days before I actually got back into the ER because of what the ER wanted me to do in order to be seen. And so they ended up finding that I had like massive amounts of internal bleeding and that I needed to have my tube removed immediately. And following that, they actually didn't have any answers on what the fate of my reproductive health was. And so it was not, it was actually quite depressing. They couldn't even tell me like, does this decrease my chances of having children? And they just kind of sent me off the next day. And so that was like my first entry point into it. And when I got pregnant, fortunately I was pregnant just a few months later with my first child. And quite honestly, when I say there were not being able to make choices, so I was employed by an organization, the Wilder Foundation, and the healthcare options that they had for insurance coverage allowed me to see certain providers. And one of those providers was through healthcare system. It was Park Nicollet. And I remember going to the doctor, and I had to travel really far to get to the doctor. So it already felt like it didn't work for me. And I get there, and I think it was the stress of having the previous miscarriage, but it was a really rough first pregnancy. And I began bleeding during my pregnancy, and I went in to see my doctor, and they essentially told me, and this is my first pregnancy, so I know nothing about how I'm supposed to be treated, but you kind of just feel it when you feel it. And they told me that, well, you might miscarry, and there's nothing we can do before, I think it was 24 or 26 weeks. And that was essentially like their response to me at bleeding, and it was terrifying. And they did some scans, found out I was a high-risk pregnancy. And what it led to was, for me, when someone tells you you're like high risk for anything, you think you need more care or more support in some way. And they were telling me, well, we can't get you to see a doctor for about a month out. And so I was just like, I don't understand, why it didn't feel like my health was being prioritized, and it also didn't feel like I had a choice. And so after some hours, after some time doing research, I found another system that my insurance was willing to work with, Health Partners. And I actually believe like the system stressed me out and contributed to my high risk status. And when I began seeing the nurse midwives through Health Partner System, I actually, I think after the first visit, my high risk condition stopped because I felt less stressed. I was like less depressed because the care that they were giving was a lot more attentive, and it just felt more comfortable for me. And so that first experience, pregnancy was just crazy. But then when I gave birth to her in the hospital, which is separate from the clinics, and you might have different nurses and midwives, that really changed things for me too, because I worked with my midwife to come up with this birthing plan that I felt really worked for me. I wanted to deliver naturally, all these things. But right away, when I started going into labor, things quickly shifted, so that way I was basically doing what they wanted me to do. And so I remember arriving to the hospital and I gave them my birth plan because I had it printed out, and they completely ignored it. They didn't pay any attention to it. They questioned whether my water had broke, even though I was like, my water broke. And so they were already like questioning me and what I knew to be true about myself. Even to the point after I had my child, we knew that there were some vaccines that we were comfortable with and others that we wanted to do more research on. And just recalling the pediatrician pressuring us, and that my partner had to step in and literally tell her, look, you can't expect us to trust you because of what you've done to us in our past. And so I hear you, but what I need you to do is back off. And thankfully I had someone there to support me in that way. But after that experience, I knew that the second time around, I would not be going back there. And so I did try to with my second pregnancy. They ended up drug testing me without my knowledge, which wasn't, the problem was they didn't ask me and they didn't inform me. And I felt violated in a sense when I saw my results, and I was like, oh, you tested me for crack cocaine and morphine and steroids and all this stuff. And I'm like, this is weird. And I feel like you should have at least told me about it. And so after that appointment, I left and went into Roots Community Birth Center and had a completely different experience that was amazing, spiritual, successful, loving in all the ways for all of my family. And so just really felt like a lot of times the barriers that I had was not having a choice, and the quality of my care was just poor.
Yeah, so I kind of touched on it a little bit. Like, I had my first daughter at a birthing center, and that experience was phenomenal. And I knew with our second daughter, we wanted to have another birth experience or birth center experience. But that time in my life was very challenging. It was very stressful. I was working in a work environment that was very toxic and very just kind of hard for me. Also struggling with some stuff personally. And so my mental health during that pregnancy just was not in the best shape, so to speak. And so I struggled with depression during my pregnancy. And as I was communicating that with my midwife, there was a lot of just like mistrust between her, which was really odd for me because I just thought like, oh my God, this is a birth center. So I had a great experience. This is going to be great. So like, we're going to be on the same page. Everything's going to be good. But she questioned a lot of the things that I was saying. She's like, are you sure? Like, maybe you should just like stop working. I'm like, well, if I could stop working, I probably would do that. It's not an option at all. So I was just simply asking for her to reduce my work hours. That's it. Like, I'm not trying to like quit my job or anything like that. But we went that way for weeks and weeks and weeks. Luckily, and I understand the privilege in this, but I was also seeing a therapist as well to kind of help with some of my mental health issues. And, you know, once I got really close to the end of my pregnancy and things started to progress with my depression, I said, listen, I really need something. Like, this is not going good. I'm not feeling good about this pregnancy. I'm not feeling good about my mental health. It's overall just not great. And so her suggestion was to put me on antidepressants. Now, I have nothing against antidepressants, but the problem that I had was I've never been on antidepressants. And I found it very unique that or strange that I'm at a very holistic, natural environment, and the option to solve my depression was to automatically just put me on antidepressants. And so I decided to not take that route because it just didn't feel really comfortable. I was getting closer to the end of my pregnancy. And luckily, my therapist was able to advocate for me and was able to write a recommendation to my employer to explain that what was going on and why I needed my hours reduced, which was a whole nother situation, having to have a conversation with my male boss about my mental health issues during my pregnancy and why this work environment was just not suited for my current state of being pregnant and taking care of myself. But I mean, that's a story for a whole nother day. But, you know, that was probably like the biggest barrier that I had. And it was just really frustrating because I just had such a idea of what my experience was going to be, and then to have this be to have this happen, to have this blockage of like, look, I'm not lying about what's going on with me, I'm really needing this, but you know, like I said, luckily I was lucky enough to have another person to advocate for me to be able to get the needs that I needed to have a healthy in the pregnancy and ultimately a healthy birth too.
Thank you both for sharing those personal stories, and we can hear some parallels of the importance of having somebody there to advocate for you, and also not feeling like you're being listened to. You both have organized other BIPOC mothers, BIPOC mothers in conversation about their experiences with the healthcare system. What led you to have these conversations, and how did you begin having these conversations?
Yeah, for me, so I wouldn't by no means consider myself an organizer, but my personal network is very near and dear to me. It is mostly women that make up that network, who are mothers. And so after kind of reflecting on my first live birth experience, I knew that there were some things that I had to do differently. And while my friends and family necessarily weren't preparing to have children, I knew that some of them still planned to. And so I started telling them about my experience, one, just as a way to process what I felt like had happened to me while I was giving birth and in my care. And as I was doing that, I feel like it really just, it was good for me in processing, but then other people started to think more about their birth. So my friend who, you know, her first birth was a cesarean birth, and it changed her in that when she got pregnant again, she really wanted to have a vaginal birth and sought healthcare systems that would support and encourage her in doing that. And so with breastfeeding, that was something that was important to me. My mother breastfed me, and I was one out of 4 of her children that she chose to breastfeed, or was able to breastfeed, maybe even. And she told me that even she felt like it created a different relationship between us that has even changed how we are in relationship today. And so I knew that's something that I wanted to do. And so, you know, breastfeeding is hard ass work, man. And so, again, as a way to like encourage myself, but also encourage others, was to just be really open about it and share, because I know that I watch my friends and my sisters struggle with breastfeeding, especially past about 6 weeks. And so I wasn't actually confident that I could do it, but in talking to others about it and how much that I really wanted to do it and how much I really wanted to try to stick with it, I think it really helped me persevere through the breastfeeding journey so that I was able to breastfeed, you know, for 3 years. And I had my children back to back, which is a whole nother story, but they were 13 months apart. And so I was also tandem feeding. And so it took a lot of support. And the best way I found that was in sharing my experiences with my friends and family and other mothers.
Yeah, I think my experience too was just sharing with my network, my friends, my family. And one of the things that was really kind of hesitant even sharing my story, because especially with my first daughter, like I had such a positive experience and such a beautiful experience. But a lot of times in the conversations I was having with women who either had had kids or were going through pregnancy at the time, it was always so focused on the negative experiences. Like we're sharing like our horrible war stories of how you had emergency C-section or how this happened and how that happened, that it almost made me feel like I had to get back in my cocoon about even sharing my experience, because it just made me feel like, God, was I just really lucky, or like how did I get this experience? But I also started to realize again around this idea around representation that we need more stories from Black moms who have positive birth experiences. And if there's not if there's not that many, and I'm one of them, well, then I have to shout from the treetops that I had a great experience, so that more Black moms can see that it is possible and there are other alternatives and other options out there to be able to have a positive experience. Obviously, pregnancy is one of those things that like, you kind of just don't really know what's going to happen throughout the pregnancy and throughout the labor and delivery. But what my mission, especially with my platform, Melanated Mamas, is really to amplify those stories, to give a space where moms can share their positive birth experiences, so that generations, you know, that come, they can see that, oh my God, yes, there's awesome birth centers that are right here in the Twin Cities. There's awesome resources. This is how you can do things naturally, et cetera, et cetera. So that's kind of how I started to have those conversations. And really it's just being, I guess, bold enough to just say like, yeah, this is my experience and it was great. And like, here's how I made it happen. And here's the resources, and don't give up, and be encouraging and being supportive.
Thank you both for sharing that. I kind of want to move on to kind of combining some of the topics that we've talked about today and getting from your perspective what you think we can do to eliminate systemic racism in healthcare, and what steps we should be doing in order to have better maternal outcomes for Black mothers.
So for me, it's, you know, I never fulfilled my childhood dream of becoming an OB/GYN. That's fine. Now I find myself in this position in, you know, as a human resources organizational culture manager. And I'm fortunate enough to work at Nexus Community Partners, where we, in order to ensure that our staff can come to work wholly and healthily as possible, we provide excellent benefits. So we provide benefits where, you know, we can cover up to 90% of the cost for birth. And we also have a lot of flexibility in the providers that we can see. And so, you know, I mentioned at Wilder, sorry, there's a fly in here. I mentioned at Wilder, the type of insurance that I had, what I actually found out is that it wouldn't allow me to have a natural birth at a birth center and have it be covered. And so I would have had to pay out of pocket for that. Well, if I hadn't known about the experience that I was bound to have at the hospital, and really, quite frankly, all of the trials and tribulations that they put me through, it ended up resulting in out-of-pocket expenses that were the same as doing a natural birth. And so it would have been really great if my employer provided options that allowed me to get care that is going to keep me healthy, happy, and able to work. And so it's pieces like that where, you know, we often think about healthcare systems, but, you know, in the US, much of our care is tied to the privilege of being insured. And even being insured doesn't necessarily grant you access to quality care. And so I think, you know, we don't often see our employers as having a role within the care of our health, but employers make a decision, and it's a values-based decision when it comes to the type of care that they're offering, the coverage that they're offering their staff. And unfortunately, the trend now is that a lot of employers are moving to offer care that the cost is the burden of the employee instead of the organization. And again, that's a values-based decision that I think that's where things start. You know, if you if you are someone who's insured. And I also think, for me, when I switched to Roots Community Birth Center, it wasn't even having someone that looked like me, because honestly, my midwife wasn't. It was having someone that actually cared enough about me to listen and respect what it is that I'm saying, and not question me as the person who's literally carrying a child. And like, I know what's happening in my body, and I know when things don't feel quite right. And so, but I never had to go through those moments where it was questioned. And so I think trust is a huge piece, and it's seldom acknowledged. And I think the reality is that, being that most providers are non-Black, is that oftentimes, especially if they are white providers, not only is there not trust at the onset, but there's a deficit when it comes to trust. Like, in all honesty, sitting before a white healthcare provider, I feel like there are many reasons why I shouldn't trust you right now. And in order to protect myself and my health and well-being as a pregnant woman, it's important for me to have that mistrust, because not having it could be a life or death situation. And so I think it's important for providers to understand that when you have patients of color, and especially if you are white, that don't assume trust because this is a new patient for you. Assume that you actually need to restore trust because of history.
I 100% agree with Shalon. One of the things that I didn't mention with my birth experience, going to a birth center, I had an employer that did not cover our birth experience going to a birth center. And, it was a choice that we made from a financial standpoint, that we were going to pay out of pocket, but that is a huge issue, and that's a huge problem. And one of the things that I think is important is being able to being able to shift the narrative around alternative care. I think a lot of times the idea is let's just go straight to the hospital. Let's do our prenatal care there. Let's, have an epidural. Let's do those are just kind of like the normal standards of how to deal with pregnancy and delivery. And there's just so many options out there. And one of the things I think is important is just being able to be exposed to those options. I also think we need more BIPOC women in these fields. We need women who are OBGYNs and doulas and midwives that look like us, so that we can have that trust and we can build those relationships. And then the other thing is just being able to have access to this information. Like I said, I was fortunate enough to just kind of stumble upon this information around having a natural birth or going to a birth center when I was in high school. So if I didn't have that experience, I don't know where throughout my life would I've had the knowledge to think, okay, I don't actually have to go to the hospital, because all of the other people around me, my family and friends, that's the way that they went. So I probably would have just did the same thing, because that's just what you do. So just having more access and more information out there to the alternatives to your pregnancy and your birth, and just continue to amplify the beauty that is there too.
Thank you both. If we can just kind of wrap up, and if you can give me one final word or thought you'd like to leave with us today, and let us know how we can connect with you.
I guess I would just say one is that there needs to be a lot of work done to trust in Black moms, and that we've been birthing since the beginning of civilization. And so there's a lot of history wired within us. And so listen to Black moms, trust Black moms. And you can connect with me at my Nexus email address, cwilson@nexuscp.org.
Yeah, I think I'm just going to piggyback on my last statement is, the space is a platform that I have, Melanated Mamas, which you can find us on Instagram at melanated.mamas, is to really just continue to amplify our joy, amplify our love, amplify these amazing, beautiful birth experiences so that other BIPOC moms can see that it is possible and have really awesome references to that. It's just, I think these conversations that we're having right now are super duper important because we have to have them in order to make the changes. But I think it's also important to make sure that we're continuing to share the good, because we will continue to see all of the negative, we'll continue to see all of the bad as we have seen through social media and through the news. But I feel like there needs to just be more spaces where we talk about the good and we talk about the love. So that's all.
Great, thank you both so much. I want to hand it over to Amanda for a moment.
Sorry, Asha, I came on really quick because actually we have time and I think we'd love to hear from you just with all of the research and experience you have. That last question about what can folks do to eliminate structural racism in healthcare? Would love your thoughts on that.
That's a really hard question, and I part of me pushes back on the idea of eliminating structural racism, and if that is possible in our lifetimes. I know it sounds morbid, but I question it because it really requires us as a society to dig a little deeper and ask some of the questions that we've had lingering for decades and centuries. We have the medical system is a system that was built on the foundation of racism, right? So how do you change a system that wasn't created to provide care for Black folks in this country? And I think that's hard. I think it takes a lot of dismantling, and that doesn't necessarily mean like a physical dismantling of a system, but within our minds and changing perspectives. I think we need to start training doctors and people who go through the medical education system to not focus so much on race in the biological sense. There's a lot of race-based medicine and perspectives on how people think about Black patients. We know really sad facts that Black patients are less likely to receive pain medication because providers have internalized that Black people maybe don't feel the same level of pain. So how do we kind of like dismantle those pieces that are, of course, being taught from generation of clinicians, and it really just takes a lot of unlearning. And that really starts from training from the beginning, is that there needs to be a dismantling of that system. Another thing that we really need to think about, and this goes beyond just thinking about Black mothers, but women in general, there is a tendency not to believe women in the healthcare system and in other systems as well. And to dismiss their pain, to dismiss their concerns, and to assume that they're hysterical or not telling the truth or imagining what they're feeling. And I think that that's a symptom of patriarchal ideas that we need to let go of. And it's going to take a long time and for us to do that, but it really is going to require people to do a lot of individual work and to think about what are the things that they can do in their own lives. I know a lot of people who are watching this are probably thinking, oh, well, maybe I'm not in healthcare, or maybe I really don't think that there's any structural pieces of racism that are in the institutions that I work in or have power in. And I can promise you there are. There probably are. You need to sit with that and to investigate what are the problems, what are the questions. And you can speak to the people in your communities and in your work lives and in your environments who may be more aware of this and have those conversations, open up spaces to have those conversations, and don't just leave the conversation with, it is what it is, right? So we started out talking about racial inequities, and that was kind of the perspectives that a lot of folks had, is it just is what it is. If you're Black, you're just more likely to die from diabetes. If you're Black, you're just more likely to die from COVID. Instead of actually dismantling the the thinking behind that and the pieces behind that that might actually lead to that. These are social causes, ills of our society that are causing these things, not anything that's inherently biological. So we need to kind of investigate that and dig a little deeper into having those conversations and be comfortable being uncomfortable.
Definitely. Thank you. I love how you're bringing up such a good point of, the system was created and designed in such a way to operate it the way it's operating. And so how do we think, even reframe and dismantle the beliefs that we have? And that's just so powerful. I also love the call to action that you just put out there too, and that our panelists said as well. So please know that no matter where you are, you can get involved and impact in your sphere of influence, and finding those ways and really being creative on how to do that. From the panelists, I know we have a few minutes, which is great. Any last words that you want to say or comments after hearing Asha speak too?
I don't have anything.
Well, this was phenomenal. I really, really want to just say how thankful and grateful we are to the three of you today for your time, for your expertise, and just for being so vulnerable and real with us in this conversation. Thank you for that. We have all learned so much, and just really appreciate you showing up today and talking about this important issue. And as you see, the slide is on there. There are some additional resources, so feel free to check out our website. We will send out a final kind of wrap-up email, a thank you, and we'll have the link to this video as well, the recording. And we will also send out contact information of each of our panelists and presenters today, so that you can get in contact with them and learn more about the work that they're doing as well. Again, thank you, Asha. Thank you, Shalon. Thank you, Monica. Really appreciate you all so much. And I hope everyone has a great day. Thank you for tuning in.
Bye, everyone.
Bye.
Bye. Thank you.
Thank you all.